Very good morning. So firstly, I'd like to thank ProImmune for inviting me to give this particular talk, which is a little bit different from infection. It's more about the development of a T-cell therapy against hepatitis B-related liver cancer. And really, it's a work that we are doing as a sort of prelude to developing the therapy for chronic hepatitis B. And why would I say that? I think you better appreciate it as I continue. So chronic hepatitis B or hepatitis B virus infection. The virus is a partially double-stranded DNA virus. It has a very complex life cycle, as you can see over here. But the real key point about hepatitis B virus infection is the fact that it can integrate itself into the host genome. The other important points of chronic hepatitis B virus infection is the fact that in individuals who are able to control or clear the infection, you can see a functional and a very broad HBV-specific adaptive immune response. However, in individuals who are persistently infected with hepatitis B, this adaptive immune response breaks down. So approximately 10, 15 years ago, we had the idea and we said, what if we could use T-cell therapy to kind of reconstitute the HBV-specific T-cell immunity, and can that actually help in the treatment of chronic hepatitis B? However, if you look at the natural progression of hepatitis B virus infection, so there are groups of people who have an acute self-resolving infection, and you have the people with chronic HBV infection. And a large proportion of them actually remain asymptomatic, and they pretty much have a good, healthy life for decades. And it's only a small proportion of them that will actually develop hepatitis, fibrosis, and the eventual, let's call it the severe outcome of hepatitis B-related HCC. So that means that if you want to develop a T-cell therapy for, in this case, a relatively benign outcome of chronic hepatitis B virus infection, you pretty much have to start from the most severe outcome of the infection or chronic HBV infection, which is the HBV-HCC. And for the purpose of today, I'll talk about more in these two groups, 1 and 2, as we have just recently infused HBV-specific T-cells for the treatment of chronic HBV, and we are awaiting the data. So what are the features of these T-cells, or at least these engineered T-cells that we have used in patients with HBV-related HCC? And I'll draw you to two particular characteristics. The first is that we are targeting HBV antigens. Sounds very simplistic, but it has implications. And secondly is the fact that we are using mRNA electroporation to engineer the T-cells, not viral vectors, which many of you might be more familiar with, things like in CD19 CAR therapy, where you use viral vectors to permanently modify the T-cells. So the first point, targeting HBV antigens. So clearly, if you want to treat chronic hepatitis B, you want to reconstitute the HBV-specific immunity, we want T-cells that are able to target HBV. But this is also usable in the context of hepatitis B-related HCC. And that's because, like I mentioned in the beginning, the virus is able to integrate itself into the human genome. You see that in a lot of the HBV-related HCC, you can find fragments of HBV DNA present in the host genome. So that means that the HBV antigens comes from two sources, one from an infection, one from integration, and there's a rationale to try and use HBV antigens as a tumor antigens, making use of the natural life cycle of HBV to mark the HCC cells. But it also comes with a drawback. So if we are targeting HBV antigens, these T cells are unable to differentiate between cells that are infected with HBV and cells that are transformed. So that leads me to the second characteristic of the HBV TCR treatment that we developed, which is the use of mRNA electroporation instead of viral vector transduction. And the reason why is because if you electroporate the mRNA, the labile nature of the mRNA itself means that the mRNA will start to decay. And you can see here over here that the expression of the exogenous TCR that we introduced lasts for approximately 3 to 5 days. So we have a temporally limited function of the product itself. And in addition, it is then possible for us to deploy a dose-escalation infusion strategy where we first infuse very low quantities of the product into humans, see whether there is an adverse event, and then we slowly or gradually increase the dose. Clearly, we are aware of a potential disadvantage of using mRNA electroporation. And that's the fact that there could be a temporally limited efficacy, as we have seen in preclinical mouse models that in red is where we infuse the T cells, and you can see as we continue to infuse the product, we have the maintenance or at least the suppression of tumor growth. But the moment we stop the treatment itself, the tumor growth can go up, and that is clearly because of the temporally limited efficacy of the product. So the big question, can these TCR T-cells have any clinical efficacy, considering that these are only functionally short-lived? And this is particularly pertinent, especially when we look at it in the context of the current views of T-cell therapy. The idea is that you want to have persistence over time. If the product persists in the patient, it is generally perceived that you would have destruction of your targets. So it is perfectly normal to say that if we now put mRNA electroporated T cells that have only a transient function, there is no clinical efficacy. But is this actually true? And now I'll show you some data from patients that we have treated with the mRNA HBV TCR T cells. So the first is an individual who had a living donor liver transplant and have HCC recurrence after the liver transplant, occurring mainly in the lungs. And this particular patient, because he's liver transplanted already, the tumor lesions and the liver graft are HLA mismatched. So in this way, if we target a particular T-cell epitope restricted by the HLA-B58, this is only found in the tumor and not in his healthy liver graft. In this patient, we will also characterize the presence of the HBV DNA integrations in the tumor itself, as shown over here. We know that the HBV DNA fragment that encodes for the epitope recognized by the HBV envelope-specific T cells is indeed present in the tumor lesion. So in this particular patient, we treated the patient for approximately 2 years with over 30 infusions of the HBV mRNA, and throughout the entire 2 years, we did not have any treatment-related adverse events. So here I'll just show you the efficacy data. Most of the lesions occurred in his lungs. There were a total of 6 lesions. After approximately a year, we have a reduction of all 6 lesions. And here I show you 2 representative lesions. The dotted lines are all the individual infusions. The gray is the alpha-fetoprotein, which is upregulated or at least is secreted by the tumor. So it's a proxy of the disease burden or the tumor load. And the red line shows the maximum diameter of the tumor lesion. So you can clearly see that there is a reduction and there is no rebound even at time points where the infusion is no longer given. And this is just the CT images showing that the remarkable reduction of the tumor lesion itself. But what is peculiar to us is the fact that if you look at the reduction of the tumor size, it occurred at a time point 2 to 3 months after the last T-cell infusion, which is this dotted line over here. And this is inconsistent with the functional lifespan of the product that we put in, because let me remind you, the T-cells are only functional for approximately 3 to 5 days, and yet the tumor regression occurred within this time frame of 2 to 3 months, which would then suggest that the volumetric reduction of the tumor is not exactly proportional to how many cells we put in. There's another reason, and that's what we're trying to find out. So we hypothesize that perhaps what happens is when we infuse these T cells have altered the tumor environment in some way that we have yet to know, and this led to either the induction or the recruitment of more tumor-specific T cells, leading to a secondary and more robust destruction of the tumor itself. Big question, do we actually have any evidence that the infusion of the mRNA HBV TCR T cells can, or at least alter the immune system in any way? So now I bring you to the data from primary HBV HCC patients. So just now was the first patient that we have ever tried treating with the mRNA HBV TCR T cells, and that was a liver transplanted patient, and we wanted to be extra careful. So we wanted liver transplanted patient where we can be sure that the tumor lesions and his functional liver is HLA mismatched. Now I'll show you data in 10 primary HBV HCC patients. They were also treated with the mRNA HBV TCR T cells using a dose-escalation approach. And just a note, No lymphodepletion was given to any of the patients that were treated, including the transplanted one, and there was no post-infusion high-dose IL-2 given as well. And what do we see? So I show you the data from two particular patients. So the first, B01. In gray is the dose of the HBV TCR T-cells that we infuse. In red and blue is the ALT and the total bilirubin levels in the serum, which is a biomarker for liver inflammation. So as you can see, upon infusion of a very low dose, 100,000 TCR positive T-cells per kilo, and within a couple of days, we induce a very strong liver inflammation. This inflammation resolved by itself in approximately 3 months, is totally self-limiting, and no other liver inflammation occurred even when we increased the dose. But what is interesting is the fact that this liver inflammation was actually associated with a massive destruction of the liver, of the tumor found in the liver. And this tumor is actually over 10 cm in size. So clearly, the infusion of only 100,000 TCR T-cells per kilo is inconsistent with this massive destruction that we are observing. Something else is happening. And if we look at another individual, S003, so what we notice is that upon infusion, especially at the higher doses, 3 to 5 million TCR T-cells per kilo, we start to see spikes of serum CXCL9 and CXCL10. Again, CXCL9 and 10 cannot be produced by the T-cells that we infuse inside. It is likely secreted by other cells due to an initial interferon gamma stimulation. So clearly, these two shows that some sort of immune alteration can occur when we infuse the mRNA TCR T-cells. But more importantly, if we would now summarize all the 10 individuals with primary HBV HCC that we have treated with the mRNA TCR T-cells, we can see that, yes, only one individual has an adverse event, which is this liver inflammation. But what is even more interesting for us is the fact that in all those individuals, in all those patients with some sort of anti-tumor effect, whether it's a radiological reduction of the tumor lesion or whether there's a reduction of alpha-fetoprotein, we can see that it is accompanied, or at least is associated with some sort of immune alterations, whether it is a detection of activated T cells in the peripheral blood or the secretion of serum chemokine like CXCL9 and CXCL10. So this data actually confirms that the infusion of this short-lived mRNA HBV TCR T cells can indeed induce some sort of immune alterations, and more importantly, this immune alteration seems to be associated with a clinical efficacy. In some individuals, we actually had the opportunity to analyze the HBV-specific T-cells using a rapid whole blood cytokine release assay that Nina presented yesterday. So just to remind you, the assay works by introducing HBV peptides libraries that covers the entire proteome of hepatitis B virus. You add it directly into the whole blood, and we analyze the amount of cytokines like interferon gamma and IL-2 that is secreted in response to the peptides that we have added. And we know from all our previous publications that the amount of cytokines that's being released is directly proportional to the quantity of HBV-specific T-cells. So using this assay, we can see that in this patient, S03, again, just like any chronic HBV patients, there were no HBV-specific T-cells prior to treatment. And upon treatment, you start to see T-cells that are specific hepatitis B. And more importantly, you can see that the T-cell specific hepatitis B is not just the envelope, the cells that we infuse inside, but we start to see T-cells responding to the core in red and polymerase. So again, this is preliminary evidence showing that there is some sort of epitope spreading, but more importantly, it's telling us that the infusion of these transiently functional mRNA TCR T-cells could induce some sort of immune alterations or induce changes that could provide robust clinical efficacy. So in conclusion, what I've showed you, and I hope I've convinced you, that the utilization of the mRNA TCR T-cells can have advantages that goes beyond just safety. There's actually some clinical efficacy to it, and that the transiently functional mRNA TCR T-cells can probably provide this efficacy through the alteration of the immune environment, induction of new HCC-specific T-cells, and that this feature of the mRNA TCR T-cells could be advantageous, especially when used in combination with immunomodulators like checkpoint inhibitors to try and boost the immune response. But more importantly, because like I said from the beginning of the presentation, all this work is a sort of prelude to try and develop this T-cell therapy for chronic HBV. And clearly, having a treatment that can boost the HBV-specific T-cell response will be advantageous in that particular context. So just to end off, I'd like to thank all the members of the Antonio Bertolotti Laboratory in Duke and US, our sponsor Lion TCR, our clinical collaborators in Singapore, the Singapore General Hospital, as well as in China. And yeah, and thank you for the audience for listening. I'll take any questions. Thank you very much.
So is there an opportunity to find epitopes maybe in the sort of recombination junction region of the HPV with the genome to then design TCRs that are more persistent and therefore only HCC specific?
Sorry, if I get it right?
So if I understood you correctly, the transient method is partly due to the fact that presumably the HBV infection continues to persist and you don't want sort of the persistence of the T cells unless they are longer term HCC specific.
No, the transient nature of the HBV TCR T cells that we infuse inside is due to the fact that we are modifying the T cells using mRNA electroporation and not viral vector transduction. So that's why they only express the HBV specific T cell receptors for a short duration.
But presumably you're doing that for safety reasons, or?
So we initially started for safety reasons, like I alluded in the beginning, that we want to try and use to develop it only for the most severe outcome of HBV, HCC first. But then we realized that even with that transient nature, it gives us superior safety, but it can also induce clinical efficacy. So actually we are pursuing down this line of a hit and run approach, not so much of having the cells persistently present in the body, because we have also seen from the lessons in, like for example, CD19 CAR, where the persistence of the T cells in the body, actually after a while, these T cells start to be exhausted. They start to get activated continuously, and they start to be dysfunctional. Okay. Then in that particular setting, because it's viral vector transduction, infusion of more CAR T cells don't really make any sense. So we want to avoid that part of the exhaustion. And that's why we thought that the idea of using transient multiple hits, hoping that we will alter the immune environment and induce a more robust immune response against the tumor could be a better strategy.
Okay, thank you.
A great talk.
Thank
so
you.
Now I understand that the mRNA transduced TCR T-cell can enhance endogenous HBV-specific T-cell response. Am I right?
Yes.
Yeah. But then, so I can expect that, so even if these mRNA transduced TCR T-cell are transiently present, this endogenous T-cell would be persistently activated after activation. But according to your data, they transiently present. So how you can explain about this transient activation?
Okay, so it's true that upon infusion, we see upregulation of hepatitis B. But I do not believe that the upregulation is only for the HBV-specific T cells. I believe that there is also an increase or at least recruitment of HCC-specific T cells. The problem there is that it is difficult to analyze because we don't know what these HCC-specific T cells are for. And therefore, since this is a chronic HBV patient, we use the HBV peptides to see whether there is any evidence that there's a kind of recovery. Why these are transient? Well, like you said, these HBV-specific T cells are dysfunctional. I don't think it's as simple as just activating them and causing them to reinvigorate them and suddenly they will persist because, as you already know, there are a lot of even epigenetic modifications, deletions, and all this exhaustion that are very permanent, and efforts to try and do therapeutic vaccination have failed. A lot of efforts to try and reinvigorate these T cells have failed. So again, as you can see, the T cells don't go up and stay up. The HBV-specific T cells went up and it went down.
Then what will happen if you co-administrate the anti-PD-1 when you infuse mRNA the TCR T-cell?
That is essentially, I mean, if the clinical trials allow us to do it, that's essentially the idea, to say that if we now put T cells that can trigger the initial event, followed by either checkpoint inhibitors, or now there are even small molecules that can boost the immune response, can we trigger more epitope spreading, and can that be beneficial? So that is something that we are thinking about, and we are actively discussing with the sponsor, Lion TCR.
Thank you.
Thank you.
Hi. Very nice demonstration of the epitope spreading by your TCR therapies. So my questions, so your mRNA-transfected TCR T-cells, it's very important to trigger the downstream event of the epitope spreading, right? So do you do anything on those T-cells so that they can accumulate to the tumor sites?
So no, at the moment, these mRNA TCR T-cells, we don't put particular modifications like either chemokine receptors or integrins or anything to try and focus its migration to tumors. We have never done any of that yet. So I agree that that could be the next step. And I think that also partly explains why we see very good efficacy in the first patient that I showed, because the tumors are actually present in the lung. So by just normal infusion, we know that these cells will tend to accumulate in the liver and the lung, but not so much in places like the bone or in the gastrointestinal areas or things that are less innervated by blood vessels.
All right, thank you.